Welcome back to PedScript. I'm Zach Hodges, a pediatric critical care fellow in Dallas.
And I'm Alice Shanklin. I'm a critical care fellow in Washington, D.C.
Well, Alice, it's been a year.
It has been a year of podcasting, a year of PICU fellowship. It's been fun, right, Zach?
Oh, it has been. I really appreciate all our listeners who have tuned in along the way. I would say that this year has definitely been challenging in the context of my professional training, but I've really enjoyed having this podcast as like a creative outlet, and I really appreciate, again, everyone tuning in along the way.
Yes. I want to thank everyone for listening, and I also want to thank my attendings and especially my residents for their patience and their support.
It's something that we should say. We should, again, thank all of our guests who have helped make this project possible and the ones that we have lined up to join our podcast in the near future.
Absolutely. So, Zach, what are we talking about today?
So today is a favorite topic among PEDS ICU fellows. This is a collaborative episode with the Cribsiders Pediatric Medicine podcast on pediatric ARDS.
Yes, and today we are interviewing Dr. Yehya. Dr. Yehya is an associate professor of anesthesiology and critical care medicine at the Perelman School of Medicine at the University of Pennsylvania, otherwise known as CHOP. He is an expert on pediatric ARDS, and we were so excited to pin him down for an interview.
That's right. And our conversation lasted over an hour and a half, and we're going to split this up into 3 different episodes to make it easier for our listeners. Part 1 is really on diagnosing and the definition of ARDS, and we also talk about how we can risk stratify our patients between mild, moderate, and severe disease.
Yes, this is a fantastic conversation. Let's get right to the episode.
Sounds great.
If everyone's ready to get started, I am just so happy that we have Nadir, Yehya here. Thank you for coming on the show. And I'm pronouncing your name right. Is that correct?
Close.
Nadir, Yehya. And just for the purpose of the show, can we just call you by your first name, Nadir?
Please.
All right. Excellent. So, we're in an informal group, and so we just want to sort of start some get to know you questions. So, so our audience can get to know you a little better. Can you give us sort of like a, not necessarily a one-liner, but, a couple lines of just describing yourself so we know who we're talking to?
Sure. I'm a intensivist at Children's Hospital of Philadelphia. I'm a married father of 2 little girls, 2 and 5. I am probably a little bit too comfortable with conflict, and I watch an inordinate amount of football, and I have to tell myself constantly like how terrible professional football is for everybody involved, and that lives in tension with how much I enjoy it.
Excellent.
That speaks to me a lot, actually. I feel like I'm the exact same way.
It's a constant struggle.
Let's go with Alice first. Do you have any questions?
Yeah. What is a book that every physician should read?
So in all honesty, I really wish that every physician would read the red-covered CRC Press biostats and epidemiology textbooks, just so we can stop doing stupid statistics over and over and over and pretending things that economists and statisticians have figured out like a century ago are suddenly being reinvented here. And knowing that that's unlikely to necessarily actually happen, I do like the book Better by Atul Gawande. I don't always love medical nonfiction, but I do like Better because it kind of gets at that tension that a lot of us have where we're operating with imperfect information and we're going to make mistakes. And just the nature of how little we know about the body, how little we know about physiology, coupled with the fact that you're forced to make decisions in a high stakes environment with limited information, you're occasionally going to be wrong. And that book, I think better than some others, leans into that as a necessary part of learning so that, once you have made a mistake or once you've encountered an error, like what are you going to actually do with it after you've gotten over the initial period of processing it and feeling bad? Like you can let it paralyze you and let it affect the next 10 decisions you make are like reactionary to the last mistake you made versus like trying to grow from it in a way that really you're obligated to the next patient to like actually have learned from that last experience. And I think that's the best you can do. And so like I think that book gets at that better than most others that try to tackle that topic.
Fantastic suggestion. I don't know if we've had that one yet. So we'll put that on the list. Thank you so much.
Awesome. Yeah, no, I try to be original.
Zach, you got anything?
Write down the biostats thing too, man. That's
we'll do. We'll get that on there.
I was kidding about that.
It's on the list.
Literally any EPI's textbook would be acceptable.
Yeah. So maybe a spinoff from your book suggestion. Do you have a favorite failure that you'd like to share with us and maybe what you learned from it?
I I have a failure. Favorite failure is a tough one. I was a second-year resident at Children's Los Angeles, and I'd been taking care of a patient on an overnight call, and I had known this family like off and on. The patient had been in the hospital for therapies, as many onco patients are. And in this particular instance, I was asked to start a infusion of tacrolimus. And the attending going out the door told me the dose, and I ordered the dose. And sometime at around 8 or 9 o'clock, pharmacy called me and said, that dose seems high. Are you sure that's the dose? And I was like, that's the dose. It's the dose I wrote down. That's the dose I ordered. That's the dose. That's what they told me. And I was super wrong, like tenfold wrong. Like I shut the kids' kidneys down and put them into fluid overload ARDS, and they ended up getting coded, bagged, intubated that night. And I told the mom the next morning that all that had happened. And the lesson there in retrospect is obvious. Like pharmacy called me on a mistake, and I just powered through, and like the right move at that point would have been to like, question that and be like, how confident am I of like how right I am at that moment? Because somebody else who's highly qualified and highly trained has just called me on something and said like, that thing you ordered seems very wrong. And that is not what I did. And so like, I obviously learned that aspect from it, but that actually doesn't make it my like favorite mistake. When I told the mom about it the next morning, and I went home and like, kind of felt like bad for about a day. Then the kid's still in the PICU the next day. And I'm doing like now a daytime service on oncology. So it's like 4 floors away or something like that. I forgot exactly what the layout was, but it was like not next door. And I'm still in onco. The kid's still in PICU. And they wanted to do something. The PICU wanted to do something. And the mom asked my opinion because she knew me and trusted me. That was the lesson.
That's very powerful. Thank you for sharing that.
Like a day later.
It seems that
I didn't mean to bring the tone down, but you asked.
It seems like the lesson learned from the mistake is owning it with your patients, and the bond that formed with this family was very meaningful.
Yeah, that's exactly it.
I don't know what we can follow that up with.
How to handle error is like a big theme in my own, for better or worse.
Consider myself an expert on errors.
All right, so let's get right to our case from Cashlight Children's. So our patient, Mo Peep, it's a previously healthy 4-year-old boy who's admitted to the PICU from the emergency department with respiratory failure. His mom reports that the past 2 days, Mo began having symptoms of fever and cough, but over the past 24 hours, he's developed worsening shortness of breath and irritability. In the ED, he was volume resuscitated, given antibiotics, and intubated due to low oxygen saturations despite 100% oxygen with a non-rebreathing face mask. He's now sedated and mechanically ventilated in the ICU. The team is concerned that he's developing ARDS. So to jump right into our conversation, will you tell us exactly what we mean when we say a child is developing pediatric ARDS?
Absolutely. So the patient's definitely developing ARDS. The underlying thought process there is that they're developing acute. So this didn't happen chronically. This isn't like an interstitial lung disease, which is happening and getting worse over weeks to months. This is acute, which we operationalize as like whatever got them into this mess got them there within 7 days. It's respiratory. So that's the acute hypoxemic respiratory failure part of it. This is primarily like a lung specific organ failure that we're talking about. And so that's operationalized by either PF ratios or oxygenation indices or the equivalents of those using the pulse oximeter. And it's not explained by cardiogenic or hydrostatic pulmonary edema. So this isn't like an anuric patient who became fluid overloaded and flooded their lungs. This is a heart failure patient with elevated left atrial pressures causing like pulmonary edema. This is like an inflammatory exudative, like barriers are breaking down, endothelial and epithelial barriers in the lung are breaking down, and an active inflammatory process is pushing protein-rich exudate into the alveolar aerospace, and that's what's flooding their lungs. And so it's acute, it's respiratory, it's distressing, it's a syndrome. The syndrome part of it is actually like, I wouldn't even ignore that aspect of the definition. The ARDS in and of itself is about as helpful as saying that somebody has cancer. And so it's accurate, but it's not particularly helpful as saying like that somebody has Philadelphia positive leukemia or something like that, right? So a lot of times in this patient, and from that prodrome that you're describing, it's probable that that patient has ARDS secondary to a direct pulmonary infection or like a pneumonia. So like a pneumonia ARDS would be a more helpful categorization. And that helps like reduce the syndrome to something like, okay, this may need antibiotics in addition to the supportive care for helping their lung organ dysfunction actually operate. And so if that were like aspiration ARDS, you may come up with a different answer. If it were like ARDS after cardiopulmonary bypass, you may come up with yet a different answer as to like what supportive measures are needed in addition to the lung-specific failure that you're talking about.
One question I have, so when we say pediatric ARDS, is it the same as any ARDS like with adults? Would it be similar pathophysiological processes, or is it just little ARDS?
It's ARDS, but cuter. Yeah. It's the short answer is that we don't know, but it's a little bit of a cop-out when we say that. So ARDS, when it was initially described by Ashbaugh in 1967, had two patients that were like around 18 years old, if not actually 18. And so they could have fallen under the purview of pediatrics. And the subsequent ways to define ARDS, when it was initially called adult respiratory distress syndrome, reflecting off the fact that it looked a little bit like surfactant depletion neonatal RDS or respiratory distress syndrome. So like preemies, which are born in a surfactant deficient state. And then in the 80s with the Murray Lung Injury Score, and then in the 90s with the AECC definition, where it became acute respiratory distress syndrome, that was a little bit of an acknowledgement that kids also get this shock lung phenomenon. We just don't know exactly whether it's exactly the same, but they seem to have a similar sort of problem with it. And by and large, the triggering etiologies, although the percentages may be a little bit different, are still primarily infectious, mostly pneumonia, and then non-pulmonary sepsis, and then a smattering of other things like aspiration. Back in the 80s and 90s, blood transfusions and trolley were invoked more, aspiration, trauma, pancreatitis, cardiopulmonary bypass, burns, other sorts of inflammatory, occasionally infectious injuries that would trigger it, but most commonly by pneumonia and sepsis. And so in that sense, yes, it seems to be a very similar phenomenon, just tinier, right? It's like it's just occurring in tinier humans, where like you have the same acute inflammatory pulmonary edema caused by something else, which is causing respiratory failure bad enough to typically need intubation. And so that can be oversimplified to missing some of the key differences between adult and pediatrics. So animal models have suggested that for the same degree of insult, younger animals will mount a less robust inflammatory response. So for the same level of like inciting injury, you'll get like lower levels of IL-6 and TNF-alpha. And it'll take higher tidal volumes to cause a comparable amount of ventilator-induced lung injury in a smaller animal than it does a bigger animal. And this is even normalized to their relative body weights or their FRC or whatever way you want to like kind of try and compare apples to apples as best you can. But there is this sense that kids may not necessarily have quite the same inflammatory milieu, even though the setup and the clinical presentation can look very similar. And this is corroborated to some degree, although indirectly, by the fact that the mortality rate for pediatric ARDS is approximately half of what it is for adults. And that's at all levels of severity. And so adult mortality rates hover around like 40%, pediatric ARDS mortality rates hover around 20%. Severe ARDS mortality rates hover around 60%, and for pediatrics, it's about half that at about 30%. So that certainly could be explained by the differences in comorbidity that adults versus children have. Like they have different comorbidities, and and some of that could also be explained by how you choose to enact a DNR or pursue limitations of care differentially between older people and children. But it does raise the question that it's not entirely clear that we are in fact talking about the same process, even though nominally there's many similarities. And then neonates, don't even get me started. Like neonatal respiratory distress syndrome is a surfactant deficient state caused by prematurity and immature lung development. But if one of those babies gets pneumonia, then they could have an inflammatory exudative process, which is very similar to ARDS in any other context, right? But how a preemie handles that with their immature immune system, underdeveloped lung, and naturally surfactant deficient state, that's a whole separate question as to like, are we still talking apples to apples at this point, even though all of them fall under a syndromic umbrella, which is about as helpful as calling all of that stuff cancer.
Oh, wow. Thank you, Nadir. That really shines a light on the clinical variability. And I appreciate the idea that the inflammatory milieu is different in children than adults generally. As we define this syndrome specifically, how heterogeneous it might be, We've moved recently, or at least in 2015, from the Berlin definition to the PALIC definition. The Pediatric Acute Lung Injury Consensus Conference definition?
You got it.
How would you describe that change?
So PALIC was building off some of the strengths of the Berlin definition in adults. And so what we really liked about PALIC was that it was pediatric specific. And so there were a few changes to it relative to what some adults had done at that point. The adults had used mild, moderate, and severe. They introduced a minimum level of CPAP. And they otherwise operationalized some of the vagueness of the 1992 AECC definition, the American European Consensus Conference definition. So we liked what some of their formalization had done. So like acute became formalized to within 7 days. The pulmonary capillary wedge pressure of less than 18 became formalized to recognizing that people don't place PA catheters anymore, became formalized to, look, just either get an echo or just have a pretty good idea that this isn't heart failure. Bilateral infiltrates or bilateral opacities in pediatrics, in a nod to the really poor inter-rater reliability of x-rays, just became new opacities. And so it could be unilateral or bilateral. And probably the most striking change is that the pediatric definition for ARDS used oxygenation index rather than PF ratios. And it introduced a fourth category of unstratified by severity, just called non-invasive pediatric ARDS. And so like if you were on a non-invasive interface but met PF ratio criteria, then you could have ARDS. You just weren't stratified as mild, moderate, or severe. You were just called NIV. And then mild, moderate, and severe was restricted to intubated ARDS and defined according to oxygenation index. And for both PF ratios and OIs, they gave the SpO2 equivalents of SF ratio and OSI. And so that was a nod to the fact that you can have a fair amount of hypoxemia, but not everybody. There's a lot of institutional variability in terms of who gets arterial blood gases and who places arterial lines. And so you didn't want to restrict enrollment for studies or for cohort studies or for trials to people who like mandated getting a blood gas if that wasn't within the workflow of whatever institution they were working in. And so like you still want to include those subjects because they probably had ARDS, they had hypoxemia, you just needed a different way to measure it. And so I think the use of unilateral versus bilateral chest x-ray and the use of OI and OSI instead of PF ratios are probably the major deviations from Berlin. But otherwise, it like adopted a lot of the same structure as Berlin because I think PALIC did appreciate the formalizing of some vague concepts that Berlin was trying to do.
Hey, I'm Ciara Minova, a graduate student of Psychology and Neuroscience of Mental Health at King's College London, and I'm so excited to share with you my new podcast, which is called Behind the Stigma. Every other week, I will be mainly talking to the podcast clinical psychologists, clinicians, researchers, educators in the field, you name it, basically people that I find so inspiring and that will help us understand the latest research, concepts, but also complexities and controversies surrounding mental health. These are going to be some great discussions and a peek into the fascinating world of psychology, neuroscience, and psychiatry.
So just to summarize for our listeners, especially those who are not yet critical care trained, would you mind just walking us through the definition for ARDS right now for pediatrics? And that's a great,
sure.
Just some of the definition criteria, Absolutely. So we have the numbers for our general pediatricians.
So the acute is formalized as having an inciting insult within 7 days of meeting the rest of the criteria. And so like you couldn't have had your pneumonia like 3 weeks ago and now you're hypoxemic. It's like you need to invoke something new that happened within the last 7 days. The chest x-ray criteria is defined as new opacities that are not atelectasis or pleural effusion. The opacities can be used by x-ray most commonly, and but if you had a CT or ultrasound, we would probably allow that. Although like the definition doesn't explicitly say that, but like there's some nod to like you need some sort of imaging criteria to get you there. The pulmonary edema, which is presumably what the opacity is representing, cannot be hydrostatic. And so you need some evidence. If you have some suspicion that this could be hydrostatic pulmonary edema, then like you need some way to prove that it's not that. So you can certainly have sepsis with myocardial dysfunction and ARDS. And so then what you're saying is that the heart failure is only partly explaining the pulmonary edema, but the overall sepsis inflammation is explaining the rest of the pulmonary edema. And so this patient does in fact have pediatric ARDS. But if you had somebody with just straight myocarditis or dilated cardiomyopathy, and so you look at that X-ray and you say, you know what, I think 100% of this pulmonary edema is due to LA hypertension and cardiogenic pulmonary edema, then that patient would not have pediatric ARDS. And that retains a bit of subjectivity. And it's not any more or less subjective, frankly, than a wedge pressure, but the clinical interpretation does open itself up to some subjectivity. Finally, the severity stratification is NIV, mild, moderate, or severe. So NIV requires you to have a PF ratio less than 300 or a SF equivalent. The invasive intubated, that is to say intubated definition, OIs of 4 to 8 are mild, 8 to 16 are moderate, and greater than 16 are severe, with SpO2 OSI-based equivalents for each of those that are listed in the table that define them. Patients with cyanotic heart disease and who are chronically mechanically ventilated can also have pediatric ARDS, but their severity is undefined. They just need to have a deterioration in oxygenation above their baseline or worse than their baseline, but they also do not get any further stratification beyond that.
So as a clinically practicing med-peds doctor, it's been a long time since I've been in the ICU. And we're saying a couple of things that I don't quite recall. So what is a P to F ratio? Could you explain that a little bit? Might help, of course, mostly for our medical student listeners, but definitely I could use that as well.
No, of course. So the PF ratio is the ratio of the PaO2 on an arterial blood gas to the FiO2 presented as a fraction of inspired O2, which varies between 0.21 or room air and 1 or 100% oxygen. And the FiO2 part of that equation is most accurate in intubated patients because there you're getting 100% delivery straight into your lung. And so that would be the most reliable of the measurements of FiO2. And the PALIC definition operationalizes the PF and the OI in such a way that that it tries to tell you how to calculate the FiO2 if you're on a non-invasive mode to get you as close as possible to an accurate FiO2. And then in an intubated patient, you're using oxygen index or oxygen saturation index. And that is the PF ratio essentially normalized to the mean airway pressure. So it's the mean airway pressure divided by the PF ratio would give you the oxygenation index.
So I understand the PDF ratio, and I understand you mentioned earlier that PALIC, one thing they wanted to do was to add on the oxygenation index or the OSI. What advantage does that really have for us at the bedside taking care of these patients?
That's a great question. So one of the questions that the pediatric group had was, is a patient who's on a PEEP of 10 and a mean airway pressure of 15 and whatever PF ratio you get with that, is that the same patient as if you were on a PEEP of 20 and a mean airway pressure of 25? And if you got the same PF ratio, should those two patients be categorized the same severity, even though one of them is getting twice the amount of PEEP? The Berlin group also thought about this. The Berlin group actually, in the long text of the JAMA article talking about Berlin, they said that for the severe category, they thought about making severe ARDS for adults actually require a PEEP of 10, and that did not improve the area under the curve for mortality discrimination, so they discarded that as part of their definition. In pediatric ARDS, when the PALIC group was thinking about this, they thought that OI captured the concept of what they were getting at a little bit better than establishing mean airway pressure or PEEP cutoffs across the mild, moderate, and severe stratifications. And so it kind of incorporated the degree of support into the PF ratio. It incorporated the degree of ventilator support alongside the degree of hypoxemia to give you a summary metric, which may be a more accurate reflection of how sick the kid is. In prospective studies, OI marginally, but consistently outperforms PF ratio in terms of discriminating mortality. A deeper, more annoying question is actually whether mortality discrimination is the best use of a mild, moderate, severe severity stratification, Or are there other things that you could use that the definition should be doing other than predicting mortality? But the long and the short of it is that that's how we got to OI and OSI, is that like we wanted some way to like incorporate like degree of support, because we thought that there was a problem by assigning people with vastly different levels of ventilator support, but the same nominal oxygenation to the same severity category. And we needed some way to operationalize it, and OI was built in. And pediatrics, because of NICU and ECMO, was used to thinking in OI as much as it was used to thinking in PaO2 to FiO2 ratios.
Maybe just a quick review for our listeners and our learners and medical students. The main determinants of oxygenation are your FiO2 and your mean airway pressure. And the OI allows you to incorporate that mean airway pressure, essentially through PEEP, into describing how severe your patient's ARDS is, if I got that right.
Yeah, it's perfect.
Awesome. And then just to also summarize, we talked a little bit about some of the common causes of pediatric ARDS. We mentioned pneumonia, we mentioned sepsis, but just to complete the piece, is there anything specific that we should think about when we think ARDS big picture in our differential diagnosis?
I definitely think that infectious causes are responsible for about 75% of ARDS. And like broadly, pneumonia, infectious pneumonia, many of which are caused by viruses, and you're never going to grow a actionable bacteria. But in immunocompromised patients, definitely like look really hard for an infectious source, because one, they're immunocompromised, and so there's certainly a risk for a infection of some kind or another, whether viral, bacterial, or fungal, or cryptic, or weird, or otherwise, right? Like, but that is a population in which I would look harder than average for making sure that I'm not missing a treatable infection. And then other things which could cause, like in a gross categorization, is direct versus indirect lung injury. And so that's a way of thinking about whether the lung epithelial barrier is damaged first, and the injury came in from the airway side and then spread to the rest of the lung, or indirect lung injury, in which the injury propagated through systemic inflammation and may have damaged the endothelial blood vessels first and then invaded the alveolar epithelial space. So direct lung injuries are examples of like pneumonia, but aspiration, smoke inhalation, drowning, like charcoal aspiration after an ED toxicology misadventure gone bad, things like that. And indirect lung injuries are things like sepsis is the prototypical like systemic process, which probably hits the endothelium first and then the epithelium. And then you also have things like cardiopulmonary bypass, CART19, or engineered T-cell therapies and other versions of like engineered T-cell therapies and the associated cytokine release syndromes with them, pancreatitis. I'm certainly missing a few, but and cardiac arrest, for example, is probably something which can cause ARDS, but which is a combination of like systemic inflammation that may be involving blood vessels before it actually directly affects the lung. But broadly, those are some ways to think about categorizing where the etiology of ARDS is coming from.
Oh, wow. And definitely sort of the bread and butter of pediatric critical care medicine, right? All of these things, from transplant to drownings to... I do have a question. So you are an expert in this area. When you're on a stretch of service... when you're on a stretch of service and you're looking at your numbers in the morning, what value do you find yourself calculating? How do you trend it? And how does that change the way you're thinking about your patient in the day-to-day?
That is a phenomenal question. OI and is probably the value that is not immediately obvious to me. And there's the gestalt of knowing that yesterday my patient was on a PEEP of 12 and 50%, and today they're on a PEEP of 10 and 40%, and the next day I round on them, they're on a PEEP of 8 and 30%. There's that overall trend that doesn't require me to necessarily do any math. But calculating an OI in the background, because it's for whatever reason, although you would think that we can put people on the moon, but we can't, get an EMR to give a consistent oxygenation index in my flowchart. That makes it a variable that like is helpful to track. And I've actually, there have certainly been times where I've been rounding and there's an uncertainty as to whether a patient has plateaued or is actually getting worse or is getting better, because one variable may have gone up, but the other variable may have gone down. And trending out a summary metric like OI has actually been quite helpful in terms of saying like, no, this dude's getting worse. And we should actually be like, if this patient is getting worse, then we should either reconsider what we're doing. Like, are we in fact maximizing this current therapy and we just need to ride this out because this is the natural history of whatever they have? Or should we be thinking about what to do for refractory ARDS and our next set of therapies that that we may need to invoke beyond the basics of supportive care.
Sure. It seems people start talking a lot more about OI when it gets above 20.
Certainly true, because, and I think that speaks to the fact that, like, I think the gestalt that you have under 20 is that the patient is manageable, or like the settings are not that bad, and that this is like this is not something that I need to go through the exercise of like calculating every single time on round. You can broadly tell whether somebody is like better, worse, or same without going through the entire math of like either of calculating either a PF ratio or an OI. You can kind of tell, like from the ventilator settings and the FiO2, that the lung is either adequately recruited or not, and that the degree of support is either tolerable or not. And it's only when the numbers start exceeding that you're like, okay, let's do some math here. Whoa, that's actually sicker than I gave him credit for. You know, that kind of that's it, and it's right around 16 or 20 or severe pediatric ARDS according to the palate guidelines when people do start like noticing those numbers and caring about them, which could also be true in adults. I think people like when Ashbaugh described ARDS, and not to belabor this point, but the 1967 description of ARDS was patients who were having trouble hitting 100% saturation on 100% of FiO2. So like these patients were PF ratios less than 100. And so these were the severest of the severe that are generally being described if you like worked out their PF ratios, right? And so a lot of, and there's a tacit acknowledgement of this if you look at the more recent adult trials as well. All the negative trials, except for the tidal volume trial in 2000, okay, like all of the negative trials have recruited patients with PF ratios less than 300. But the neuromuscular blockade trial in like, I don't know, what was that, like 10 years ago now? And that recruited patients with PF ratios less than 150. And the proning trial recruited patients less than 150. And the ECMO trial had very stringent oxygenation criteria. So there's even an acknowledgement, a tacit acknowledgement that like that the milder and moderate forms of ARDS may not actually need the degree of intervention and support that the more severe versions of ARDS need. And there's a tacit acknowledgement of that, whether the adults choose to formalize that or not, or acknowledge that or not. There's a sense of that happening in adult ARDS as well. The only positive trials come from the sick patients.
Yeah, that's where there's work to be done, right?
Exactly.
The sickest kids.
Oh, yeah. And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscriptpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review in your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.